Good morning, everybody, and thank all you guys for giving up part of your morning. I hope you guys find this enlightening and perhaps even entertaining. So, we're going to look at the basics of the Medicare system. We're going to break it into two parts. The first part, the process of entering the system, and the second part, navigating through the system and selecting the additional private insurance products that will go along with the basics of Medicare Part A and Part B. So the idea of this presentation is to give you a fundamental understanding, a foundation in being able to navigate through the Medicare system. It anticipates that you're looking forward at some point in the near future to entering Medicare, or at least Medicare is coming up on your radar. And obviously you're concerned about making sure such an important part of your life from this point on is going to be approached with a certain deference and a certain appreciation of making the right choices. So this is what this is about. The idea of Medicare goes back more than 50 years ago. And when it was created, it was originally anticipated to be a self-contained system and to serve the purpose of making sure that people that met certain criteria, certain eligibility standards, were guaranteed a fundamental platform for healthcare coverage. And the reason that was so important back in the early 1960s is because prior to Medicare's creation, prior to Medicaid's creation, which both came about in the mid-1960s, individuals that would normally have been eligible for Medicare, people that were older, people that were disabled, people that were suffering from certain chronic diseases, well, those individuals found it essentially impossible, certainly incredibly difficult to get private insurance. If they were working, while they were working, most likely they had some form of insurance provided by an employer. That was significantly more than half of the working population, even back in the 1960s. But once you stop working, there was a decided drop-off in the accessibility of healthcare coverage. Before there was Medicare, before there was Medicaid, once you stopped working, it was likely that you would have no insurance because you were either too much of a risk or the product that was being offered was too expensive for you to be able to afford it. And even for those that were able to afford it, made a commitment to getting that private insurance post-employment, they often found that when they needed it the most, when they were facing an expensive, chronic condition, the insurance failed to deliver. The insurance would drop them at the end of that current year, or the insurance would simply deny claims, compelling them to go into litigation, which the insurance companies believed the odds were in their favor, that they would drag this on to a point where the beneficiary would simply give up or pass away. This was a big deal within the context of government's commitment in the mid-1960s to intervene where there was a deficit in private enterprise and the normal commerce. The states individually weren't able to come up with something effective, and this, at that point in time, was felt to be the only solution for government intervention for the working class, the middle class, to make sure those individuals had access. And was always presumed to be a relatively simple operative process. Those days have changed. But when it was created, and in the minds of those creating it, this was to be a system that people could easily get into once they reached a certain basic criteria of eligibility, navigate through it relatively efficiently, and it would be a system which would allow them to operate without the reliance on private insurance products. That was the idea. And for a while, it worked that way. Within a decade, though, it became apparent that as people were using more and more healthcare services under the Medicare system, and the cost of those services became an escalating burden to the federal government, the federal government had to make a hard decision as to whether or not they were going to be the singular comprehensive coverage or whether they would pass that responsibility, at least in part, to, ironically, private enterprise, private insurance companies. And that was the road chosen. So over the past decades, more and more of Medicare's responsibility has been intentionally, purposefully shifted to private insurance. And in that context, it has opened up the door to the complexities of a hybrid system. Government and private enterprise attempting to work together to deliver a product for individuals that met the criteria. So Medicare is still a federal program designed to provide a basic healthcare coverage platform for those individuals that are qualified. Currently, the agency administering it under the federal government is the Centers for Medicare and Medicaid Services, CMS, which is under the federal agency Department of Health and Human Services. When you enroll in Medicare, though, you're not directly connecting with CMS. You're doing that through the Social Security Administration. Or if you work under the Railroad Retirement System, you're doing this under the Railroad Retirement Board. For purposes of simplification, and also because when you initially touch with the Railroad Retirement Board, they're going to shift the enrollment process ultimately over to Social Security anyway. So when I say Social Security, I'm also encompassing the RRB as well. And the reason Social Security was brought into this process primarily was because back in the day, the expectation was individuals were entering Medicare at the same time they were entering Social Security, the magic age 65. And so since they were going to be navigating into Social Security benefits anyway, it was presumed, then allow that agency also to have the responsibility of making sure the individuals were enrolled in Medicare. Since then, we've split the eligibility for Social Security with an ever-increasing age requirement for normal retirement benefits. But Medicare has still stayed at 65. So we have this odd anomaly of individuals that are navigating either firstly with Social Security and then later with Medicare, or vice versa, and it's still Social Security's responsibility. Inherently, the characteristics of Medicare, which has pretty much stayed the same, although they've abrogated the pure responsibility of coverage to private insurance more and more. Medicare itself is still a fee-for-service system, which means that the expectation of what Medicare actually covers through the providers that have agreed to work with Medicare, those providers have an understanding that they will submit, if Medicare is the primary coverage, directly to the Medicare system. And the beneficiary, you guys, also have the expectation then that you are not going to pay that portion that represents the fee for service that Medicare or the private insurance under Medicare would pay. There very likely is going to be cost sharing. Built into the system has always been some cost sharing to the beneficiary in the forms of deductibles or co-payments or co-insurance. And this was really back in the 60s a minimal commitment on the part of the beneficiary. It was anticipated that the lion's share of the cost, especially inpatient costs, which was really the biggest point of why Medicare was created, to guarantee that if you went to hospital, for all intents and purposes, the lion's share of the cost of being inpatient was covered back in those days. But as the cost of care itself escalated, that percentage represented a larger and larger real dollar amount. And that was really the point why it was a decision either to escalate the percentage of coverage that Medicare would be responsible for, or shift that responsibility for that portion Medicare didn't cover to private insurance. And again, that was the road chosen. If you utilize Medicare itself, the basic government product, as your primary coverage, you have the expectation that you can go to any provider anywhere in America. I'll say that again because it's really important. Medicare presumes to be the primary coverage, that which represents the government's portion of this coverage match of government and private enterprise. Medicare itself presumes to be the primary coverage. And if it is, in fact, the primary coverage, you're going to see later there is exception to that. But if you follow that presumption, you are entitled to go anywhere in America to any provider that has agreed to accept Medicare. Now, let me tell you how comprehensive that is. Every hospital in America that seeks to be recognized and state licensed within their facility and seeks to receive any kind of federal funding, has to agree to accept Medicare. So you know any hospital you're going to go to or expect to go to is going to accept your Medicare. Over 95% of every practicing physician and every practicing healthcare provider in America also accepts Medicare every year. Usually the percentage that does not is less than 2% in any given year. And these are providers that you likely will not intersect with, like pediatricians, like plastic surgeons, like individuals that are going to primarily focus on elective procedures. And even many of these elective procedures, they're still going to accept Medicare within certain instances in which Medicare covers these services. So the likelihood of you as an enrollee in the Medicare system going to any facility, any individual provider, and having that provider accept your Medicare card is extremely likely. And that gives you incredible reach. And thus, you don't worry about the phrase, are you in my network? Do you accept my insurance card? Is there a Highmark or a UPMC facility around to make sure I can get taken care of? With Medicare as your primary coverage, that service problem is eliminated. And as a result, in line with the philosophy of Medicare's creation, to make this a universally accessible and universally usable product. Individuals that are enrolled in Medicare receive from the Centers for Medicare and Medicaid Services a red, white, and blue card. It's going to have basic information, their name, indication that this is Medicare coverage. It's also going to have their unique ID number. Now, years ago, that unique ID number was most typically your Social Security number. For obvious reasons, it was felt that merging the Social Security number with Medicare coverage was putting the individual at risk of having their Social Security number opted by somebody that would either find the card or just utilize the information in the public records. So they shifted a few years ago to a combination of numbers and letters to create a unique and usually unrememberable number. And that's usually one of the reasons you want to keep this card available in multiple places so that when it's necessary to disclose what your unique Medicare ID number is and you aren't able to do it, someone in your family, someone that is anticipating the process of integrating you into a care providing service will know what that number is. Usually, by the time you've created a relationship with a doctor or a hospital or a care providing service, they have on record those numbers, and it's not essentially that you have to provide it each time you go there. The other thing a Medicare card is going to indicate is which parts of Medicare that you are currently enrolled, or at least enrolled based on that card's information. And there's essentially the two parts. Part A, which covers inpatient care services to a large degree, and Part B, which covers a significant part of the outpatient service cost. It also indicates the date or dates that those parts have gone into. So when I'm talking to a client and they've already indicated they're in Medicare, their enrollment, I usually have them pull out their card. And what I'm looking for in particular is which parts they have, A or A and B, and when that enrollment occurred. Easiest way to know that is that card. What I'd recommend also, as I said before, have several copies of that card that can be accessible not just by you, but also family members or an individual that is your medical power of attorney. It doesn't have to be the actual card. It simply has to be the Medicare ID number and the dates that your Part A, Part B went into effect. And that can come in helpful down the road. Individuals enter Medicare based on one of three criteria. By far, the largest number of people that are in Medicare have aged into the Medicare process. It has been, it still is, and I don't know if it'll continue, but at least for the foreseeable future, eligibility is simply turning 65 years old. If you are a U.S. citizen or permanent legal resident of the United States, reaching age 65 is the only criteria that you have to meet. But there's about a quarter of the people in Medicare that are there under 65 years old. Those individuals are there either because they've been recognized by the Social Security Administration, or RRB, as being disabled, and they've been receiving disability benefits for a period of time. Typically, if you're recognized as disabled by the Social Security Administration, once you begin receiving your disability benefits, or you're entitled to those disability benefits, and a 6-month period of receipt of benefits has already occurred or has been granted, a clock starts ticking from that point for 24 months. When the 24 months are up, you're automatically eligible to enter the Medicare system through a disability criteria. One exception to that came about in the 1990s for obvious reasons was the elimination of the 24-month wait period for individuals that are disabled and their disability is amyotrophic lateral sclerosis, Lou Gehrig's disease. So individuals that present to the Social Security Administration that they are unable to engage in permanent work activities based on a condition, and that condition is expected to last either at least a year or lead to their death, establishing the criteria for disability. And if that criteria for their disability is ALS, and once the benefits begin, they're also immediately automatically eligible for entry into Medicare without the 24-month wait. Because back in the 1990s, and most likely even now, the expectation of surviving ALS for an extended period of time necessary to wait for Medicare to kick in is unreasonable given that condition. Why ALS and not other conditions? Best I can tell you is a good lobbying effort on the part of those individuals representing patients of ALS. The third criteria, coming about at the same time the exception was granted for individuals that are disabled based on amyotrophic lateral sclerosis, is individuals that are diagnosed end-stage renal. Now, in this case, it's not necessary to establish that end-stage renal has created a disability, allowing for disability benefits, although it typically does. Simply the demonstration to the Social Security Administration that the individual is at the final stage of renal disease, that they are anticipated or about to go in, or possibly even already started kidney dialysis, or they are now eligible to be on a organ transplant for their kidneys. That's immediate and automatic entry. Now, all three have essentially the same functionality of individuals in Medicare. Whether you go in based on age or whether you go in based on condition, Medicare is going to work essentially the same way. The exception to that is the end-stage renal. It has its own unique rules of engagement for access and usability. It functions mostly the same way, but with some significant exceptions. Another story for another day. My recommendation for the first two criteria, pretty much the basic utilization once you've met that eligibility. End-stage renal requires a basic understanding of those unique rules to be able to make effective decisions on how to utilize that. And I would recommend talking to someone who really understands the effective utilization of Medicare based on end-stage renal. The individual could make certain strategic decisions on healthcare insurance utilization that could limit the accessibility to services and significantly increase the costs of using those services. Beyond that, regardless of what your entry criteria is for the Medicare system, it's critical to understand that Medicare's evolution has taken us from a point of what was expected to be a simple function of government coverage to now a combination of multiple parts of coverage. And that's really the issue of conceptually grasping the Medicare system, to understand that Medicare is a jigsaw puzzle of multiple parts that fit together in specific ways, that each part works to cover specific things and integrates with the other portions of the Medicare system. So as I said, there's the fundamental platform that represents government's portion of Medicare, the Part A, which covers and has been intended from the start to cover a significant part of the cost of inpatient care. That was really the point of Medicare's creation, to make sure that back in the 1960s, the most significant economic burden of healthcare accessibility was those services provided while you were in a hospital. This is where often families either had to pass on accessing those complex and expensive services, or they were an economic disaster for the individual or the family. Medicare Part B, the other part of government's representation of Medicare, was always seen as more elective. Now, that concept has flipped over the past more than 50 years. Part A has become less and less utilized because more and more services over the half century have shifted to outpatient mode. Medicare Part B has become far more prominent in its utilization. And other parts that weren't even imagined back in the 1960s, like drug coverage, have become more and more essential in the comprehensive representation of coverage under Medicare. But what we have here on this slide is the kernel of what Medicare represents. This is the traditional or original foundation of Medicare, and it's still the component parts you have to enroll in before you can add anything else to it. You're either going to use this Medicare Part A and Part B as your primary coverage, to which you'll supplement it with private insurance, or you'll replace it in some instances with a complete private insurance reliance, which we'll talk about mostly next week, but we'll address it a little bit this week. This is some idea of the kinds of services you can expect that Part A will essentially cover versus what Part B will cover. Some things are obvious, like actual inpatient care in an acute facility, but also skilled nursing or rehab is covered under Part A. Certain aspects of home health care and hospice care. Part B, again, the presumption that the kinds of services that you obtain while visiting a outpatient facility, even part of a hospital, or going to outpatient clinics or basic care provider services at physicians' offices or care providers' offices. However, another talk for another day is the growing uncertainty of even when you are in a facility that looks like, feels like, seems like a inpatient process. You're in fact not inpatient. You're absolutely classified and thus billed by the system as an outpatient. And that can have significant cost repercussions if you don't fully understand what your status is, if you are not aware of what the effect of that status is going to be. And a significant shift, which escalates the reliance more and more on the outpatient coverage mode, is now characterizing a huge number of individuals that appear to be inpatient in hospital, in acute care facilities, now as in observation. And most individuals don't fully understand the inherent difference. It's just terminology to them, but it carries a significant import to how they're going to pay for those services, what part of the system is going to pay, and how much and what percentage is going to be paid. So again, once upon a time, it was envisioned when Medicare was created that where the most expensive things existed in the healthcare system, Medicare A would be the go-to source, which would pay close to the entire amount with a minimal marginal initial deductible cost, which was presumed to be easily affordable by most individuals. To now a point where Part A is recognized less and less and less as the go-to source for coverage, and Part B has now become significantly dominant in that. But we saw vestiges of that old premise of Part A being essential and Part B being less essential. And we've also have, as again, a historic vestige of certain things Medicare just doesn't cover. They never have, and they likely never will. Certainly not in the premise of what those costs represent. For example, neither Medicare Part A or Part B will cover the cost of routine eye care. Neither Part A or Part B will cover the cost of routine dental care, the cost of hearing aids and the process of getting those hearing aids, and neither A or B will cover the cost related to long-term care. And that's just an arbitrary premise. Long-term care is defined as being in facility for a length of period more than a certain amount. What makes it long is we've arbitrarily said after these days it's no longer medical care, it's long-term personal care. And thus Medicare, the system, or any of the private insurances that represent coverage under the Medicare system say it's no longer medical. It may very well be medical. It may very well be essentially medical in nature, but arbitrarily for the purposes of eliminating the expectation of the system to cover you, is now classified and deemed to be personal care and outside the reach of insurance coverage. And this is, again, an anomaly that was not imagined 60 years ago, because the likelihood of individuals living to the point in which they would no longer be able to take care of themselves in such significant percentage of the population was unimagined. And the economic burden that was going to place on government to pick up the cost of those individuals going into long-term care facilities for an extended time. Again, we had a choice of either to absorb the cost or to find ways to offset the cost to other sources. And again, we chose that road. Probably, though, of all these, the biggest concern is accessing coverage for dental care. And I can tell you, this is probably, after prescription medications, the biggest bastard stepchild of the whole process in Medicare. It is very difficult to find really good dental coverage. Certainly not under Medicare Part A or Part B, which will not cover what is presumed to be routine. And by the way, routine is not what you think routine is. Routine is pretty much anything. It's not necessarily routine. It could be very complex, very costly, and certainly not covered by the Medicare system. Some individuals will procure purely private dental coverage, but the warning in this case is very likely that dental coverage will fall far short of the expected quality that the individual is looking for. Not because they didn't look hard enough or were not lucky enough to find it, it simply doesn't exist. And unfortunately, this is often one of the weakest links of the healthcare coverage under Medicare. Medicare doesn't. In some cases, private insurance will give a little bit of an add-on, not very good, not very comprehensive, and procuring private insurance products usually ends up in the individual being frustrated at the lack of coverage and the length of time they have to wait before the coverage even kicks in. When an individual enrolls in Part A and Part B, they should expect, in some cases, an initial premium cost. Now, Part A, again, from its historic tradition, is likely going to be zero premium for most individuals. It's zero premium because it was expected that back in the day that Medicare Part A was so essential that individuals that would eventually become eligible had no choice in the process. While they were working, they were expected to support the Medicare system, which specifically is supporting the Part A system. As you work, each paycheck you earn is subject to a tax for the Medicare system. This is a small tax, and it's matched by your employer, or if you're self-employed, you pick up both ends. It's a little bit less than 3% of whatever the earnings are. And if you contribute, not even electively, but mandatorily into that system for a period of time, 40 quarters of the year, over the course of your working career, you've earned the expectation that your Part A has zero cost. So essentially 10 years worth of employment, and it doesn't have to be consecutive, it's simply over your lifetime, have you accumulated the necessary quarters of credit. Your expectation is your Part A has no cost. And for your spouse, if either spouse has accumulated the 40 quarters, then the other spouse is also presumed whether they have the quarters or not. You cannot merge the quarters. I've got 30, you've got 10, neither of you have 40 simply. If you have less than 40 quarters, if you have not worked long enough, or you did work long enough, you just didn't report that and pay into the Medicare system, then there is a significant cost to secure Part A based on less than 30 quarters, the cost is probably the most significant part of your coverage under Medicare, nearly $500 a month per person. Even if you've accumulated some quarters, but still not 40, say between 30 and 39 quarters, it's still significant. It could still represent the most or one of the most expensive parts of being enrolled in Medicare. Now, Part B works a little different because, again, Part B had the presumption of being more elective. So for individuals enrolling in Part B, you absolutely expect that there's going to be a premium. And that premium currently for the year 2022 is $170.10 per month per person. And it can go up based on the amount of income you have. So the base amount for everyone in Medicare now is the $170. But if your income is higher than a certain amount, in addition to that base amount of $170, you're also subject to an income-related Medicare adjustment amount, an IRMA. So for example, an individual whose income is above $91,000 and within the range of $91,000 to $114,000, not only do they pay the $170 base amount, but on top of that, a $68 income-related Medicare adjustment amount for a total of $238.10. If instead of it being an individual, it's a married couple, and that's regardless of whether both individuals are eligible for Medicare, simply if one of those two individuals is entering the Medicare system, the income generated from the federal tax return information, if that is over $182,000, then there's going to be an IRMA amount for each individual that's enrolled in the Medicare on their Part B premium. And as that income amount continues to escalate, the IRMA amount continues to escalate, added on to the base amount, so that individuals at about this point are paying as much for their IRMA as they are for the base amount. And after that, the IRMA itself becomes even larger than their base. The other thing about how this is determined, first of all, it's based on the federal tax information, but from 2 years ago. So for individuals entering Medicare based on 2022, the Centers for Medicare and Medicaid Services do not look at their 2022 income information or even their 2021 information. They go back 2 years to look at information available from the Internal Revenue Service. So every year there's a bit of a dance between the Centers for Medicare and Medicaid Services, Social Security Administration, and the Internal Revenue Service, where each computer asks the other computer for information. The Internal Revenue Service's computer is asked to divulge the information about the individual regarding their income information for 2 years ago. For in this case, the year 2020 is going to be the base determination. If in looking at 2020, it's discovered the income is above these amounts, and the IRMA is calculated effectively. Every year this changes, in that next year, 2023, the look back will be to 2021. So it is a moving dynamic. And many individuals, if they look back a couple years ago, because of different income situations, because at that point they were working more and earning more, find that disproportionately their cost for Part B is reflected based on not circumstances that are current, but circumstances that may have existed 2 years ago, but have changed. And 5 years ago, I would have said, well, you're just going to suffer this initially until eventually the pig works itself through the boa constrictor. And there is a more realistic expectation in a 2-year look back. However, Social Security and the Centers for Medicare and Medicaid Services have become more attuned, especially in the past couple of years, because of a escalation of entry into Medicare based on individuals that thought they were going to work for quite a while longer because of the pandemic, decided this was the time to throw in the towel as far as their employment and transitioning into the Medicare system. The system has become more aware and more flexible. Now, they still do a 2-year look back. They still make their calculation every year based on whatever the income information from 2 years ago was, but they will allow a challenge, and usually an effective challenge results in a reduction of the Medicare Part B premium. But you have to know how to navigate through that request for redetermination. It's not impossible, it's just a bit of a pain in the hiney. And one of the things our program does on a regular basis for individuals entering Medicare, especially in the past couple of years, I've seen certainly an escalation of enrollment, but I've also seen an escalation of requests to make a redetermination. And it's not impossible, as I said, it just requires understanding the process. It's not as simple as saying, hey, I don't think I should be charged this. The Social Security Administration, acting as the agent for the Centers for Medicare and Medicaid Services, is going to say, all right, demonstrate using a specific format and protocol. A simple letter with some basic forms attached won't be enough. There is a process you have to suffer through. And I would tell a client that it's up to you. Putting in the effort and the energy to do this, or hiring someone to do this, is it going to be worth the reduction of the IRMA? Usually for $68 a month, especially in that first year, which might not even be a full 12 months, it might not be worth it. But as that IRMA escalates to larger and larger amounts, and especially if it's for not just one individual, but two individuals, husband and wife, then ultimately the value of that challenge becomes more and more important. Regardless, expect that there will be a premium for Part B. It should be factored into the calculus of how much am I going to pay to be in Medicare, and understand that that amount can be affected by the size of your income, and the determination of that income is from 2 years ago. Once the amount's determined, whatever that is, the question becomes how you're going to pay it. Originally, it was presumed that individuals going into Medicare would also be going into Social Security, and thus the easiest way was it would be automatically taken out of your Social Security benefit. And that's still a significant percentage of the way people pay their Medicare Part A, Part B premiums, if they have any Part A premiums. But more and more individuals are postponing picking up Social Security till later, certainly after 65, or certainly after they've entered the Medicare system, whenever that is. And very common now that individuals negotiate with the Medicare system to come up with a methodology for paying. And usually the most likely methodology for paying, if they're not already collecting Social Security benefits, is that they're going to have it automatically debited from a bank account. Shortly after you've enrolled in the Medicare system, you're going to receive a letter from Medicare indicating that if you're collecting Social Security, it's going to be taken automatically out of your benefit. If you're not, you're going to be given some options of how you're going to pay it. You're also going to be notified in that letter as to what your monthly Medicare Part B premium is going to be, including an indication, if there's an IRMA added onto it, why and how they've come up with that calculation, and pointing out to you, you have the opportunity to ask for a reconsideration and a recalculation of the benefit, and a very general description of how to go about doing it, which sets you off if that's something you want to do. So let's talk about the actual process of getting into Medicare. The when-tos, the why-tos, and the actual mechanics of doing it. There's essentially two ways it happens. It happens without you doing anything. It will be an automatic process. If you're going into Medicare, the Social Security Administration will do it for you. The other way is you have to take the ownership of that process. When does it happen automatically? If you are already receiving Social Security benefits, or if you start receiving Social Security benefits at the time you enter Medicare, you will be automatically enrolled in the Medicare system. So who typically is faced with this situation? Individuals that enter Medicare based on disability. They first applied for disability status. It's been granted. Social Security disability benefits are being paid either immediately or have been paid for some period of time, and now they reach their eligibility for Medicare. The Social Security Administration will automatically enroll them in Medicare Part A and Part B without the beneficiary having to take any additional steps. If, as I said, an individual is collecting any kind of Social Security, so if they've started their retirement Social Security benefit at, let's say, the earliest they could, age 62, even when they simply age into Medicare based on turning age 65, same premise. If they're collecting their Social Security benefits at that point, the Social Security Administration will automatically enroll them when they become initially eligible at the point in where they turn 65. What you should expect is a few months before that automatic enrollment takes place, you'll get a letter in the mail from the Social Security Administration. Actually, a packet. The packet will include your new Medicare card, which will show you have Part A and Part B, the dates it's going to go into effect. It's going to tell you that you don't have to do anything. This is going to be done automatically for you. It's just sit back, enjoy the ride. But if you don't want the portions of Medicare, it's going to tell you that tough. You're going to take Part A anyway, because if you collect Social Security benefits of any kind, you're also going to get Part A, whether you want it or not, whether you would rather postpone it for whatever reason. So know that. And most people say, okay, fine, I'll take the Part A. But they'll also tell you if you don't want the Part B, for whatever reason you decide, you must affirmatively reach out to the Social Security Administration within a reasonable time before it goes into effect, usually about a month, and point out that you're going to pass on picking up the Part B. Now, again, this only takes place if you're already collecting some form of Social Security benefits, that you're tapped by the Social Security Administration for automatic enrollment and given the opportunity to at least back out of the Part B. For individuals that are not collecting Social Security at the time, for individuals that are approaching age 65, they have to take the initiative to reach out on their own to the Social Security Administration. They do it in their initial enrollment period. That's the 3 months before they turn 65, the month that they turn 65, and the 3 months following when they turn 65. This is the chart, gives you an idea of what that schematic is going to play out. So let's say this April, I'm going to turn 65. And let's say my birthday is April 17th. So my 3 prior months would be January, February, and March. If I reach out to the Social Security Administration in any of those 3 months, my expectation is I will go into Medicare Part A and Part B on the first day of the month that I turn 65. Even though my birthday is the 17th, I will enter, and everything typically is on last day of a month, first day of the month. So my expectation is my entry point for Medicare for both Part A and Part B will be that first day of April. I can still enroll and still be within my 7-month period if I waited, instead of these first 3 months, to my actual birth month. Now, even if I enroll before my birthday, as long as it's in this month, any day in this month, it won't actually go into effect till the following month, the month after my birth month. And if I wait for the 5th, 6th, or 7th month to submit my application to the Social Security Administration, I'm still within my initial enrollment period. But there's going to be a delay on the start, obviously for 1 month, but not so obviously, and you just have to know this. For every month after that, there is additional wait time. So if I waited until the month of May, I won't go in June, I'll go in July. And if I waited till June or July, there would be a 3-month wait. Why? Just don't piss off the Medicare system, I guess. It would be honestly just as simple to make it a month delay in each case, but it's not, and you simply have to know. And maybe that's okay. Maybe you, by postponing till the 4th, 5th, 6th, or 7th month, have an expectation that you're delaying for this limited time. It could also mean you simply, for whatever reason, forgot. I can't imagine, because every day once you are approaching 65, you go out to your mailbox, you're going to be reminded of the import of this situation. So usually, very, very typically, individuals do not deal with these months in the enrollment process. For all intents purposes, it's these 3 months that you're going to be focusing on. Can you reach out earlier than that? You can try, but the Social Security is going to likely turn you away. It's like, whoa, don't even bother to submit. We're likely going to put it on a shelf somewhere, in a drawer somewhere, actually, figuratively. Don't run the risk of making a too early approach to this that you actually create more of a problem. Within 3 months, that is plenty of time to reach out to the Social Security Administration if you do it correctly, and to take care of all the other things necessary to do this transitional process. One other exception. If it so happens your birthday is the first day of the month, if my birthday were April 1st instead of April 17th, then I actually get to go in 1 month early. My entry point wouldn't be April 1st, it would be March 1st, and my 3 months going in would be now February, January, and December. But other than that, your expectation is birth month, first day of the month, and the 3 months leading up to it is your ramping up time to reach out to Social Security to get it done and pick out all the additional things you're going to need. How you actually do it typically is one of 3 ways. Once upon a time, I used to tell people, if you don't mind giving up an hour or 2 of your life, go into a local Social Security office. Sit down with the person who will do the enrolling for you, and maybe you're also at that point talking about what your expectation of your Social Security retirement benefits would be. At the end of the process, you'll be told the application has been submitted. It will probably be processed within the next week or 2, and you'll get notification from the Centers for Medicare and Medicaid Services that you've been effectively enrolled for the initial start point of your Medicare utilization. Easy peasy. You could have also tried by phone. It's a little bit more dicey as to when you're going to get someone to pick up the phone, and usually it means the person who's picking up the phone is going to schedule an appointment for you rather than actually do the application right there. In the old days, simply going into the Social Security office was much simpler. But more and more, and this is even before the pandemic, was the desire of the Social Security Administration to not come into the Social Security office, do it online. Go to www.ssa.gov. And on the homepage of the Social Security Administration's website is a menu drop down. One of the menu items is enrolling in Medicare. So at this point, right now, that's really the only effective option. There are some exceptions. If there is a problem with the application process. If you don't have a computer, it could happen. If for whatever reason you're failing to get into the system, you can make a phone call. If this was a year ago, certainly a year and a half ago, I would say don't count on getting any kind of response within a timely fashion. But that's changed. And more individuals are now calling their local Social Security office or the general number. Keep in mind, you're not going to talk to a person right there on the spot who's going to do the process. They're going to set up an appointment, and that appointment, depending on the office overload and just their staffing, could take at least weeks, if not months. And that runs the risk that you're putting off a process which you could far more easily do by going online yourself and completing without risking, am I getting too close? And well, I'll just call them 4 or 5 months. They won't take your call. They won't schedule the appointment. They'll prioritize you as a minimal priority. And you're still going to end up getting closer and closer to your entry point for Medicare anyway. So my recommendation, until the offices open up, and there's an indication even when the offices open up because of staffing issues, they might still push you over to going online, or only for situations where you insist doing it, and they'll tell you, we'll call you back at some point in time. So this is the way you probably should get used to. This is probably the norm for here on after. And it's not hard. If you are remotely capable of navigating through the websites on a computer system, through the internet, then you go to ssa.gov, homepage, select Medicare application, and you're going to apply for Medicare only. It takes about 15 minutes. Basic information, name, address, social number, birthday, you get the idea. At the end, you hit submit. Up pops, congratulations, you've successfully submitted your application. It gives you a number, a application number. I'd take a screenshot or write that down, because if you ever have to refer to the process at some point, you may want to hold on to that number. About 2 to 4 weeks after, a while ago I would have said more like 6 to 8 weeks, but 2 to 4 weeks is just a reasonable expectation. 2 to 4 weeks after a successful submission of the application, you'll get a letter, snail mail this time. The letter will say, congratulations, the Centers for Medicare and Medicaid Services has been notified that your application is complete. You are now enrolled in Medicare Part A or Medicare Part A and Part B, effective on the appropriate date. If it's enrolling in Part B, you'll also receive another letter saying, oh, and by the way, how are you going to pay for it? Along with your new Medicare card. So expect the process of the enrollment takes about 15 minutes if you're doing it online. The process of getting notified that it's been successful and getting your Medicare card, about 2 to 4 weeks. And that gives you still plenty of time within that 3-month span from your initial pre-enrollment applicability to Medicare being in effect. It gives you plenty of time to also then factor in the next step, which is now reaching out to private insurance companies to pick up the supplements or the enhancements to the Medicare system. You cannot reach out to the private insurance companies first until you got your Medicare ID number. Well, you can reach out to them, but they're going to tell you, we can't really do the application. And many won't even start the application. They won't start it and put it on hold. They'll say, come back when you have your Medicare ID number. So starting that process of getting enrolled in Medicare A and B, getting the Medicare card with your Medicare ID number in place, is the first baby step towards getting to the completion, so that on the first day of the month you expect to be enrolled in Medicare. You have not only Part A and Part B, but all the parts as well. More and more individuals, though, are choosing to postpone, even when they are initially eligible, typically based on age, but it could also be based on disability as well, or end-stage renal, they are seeing the strategic value of not entering Medicare at all. Again, for those individuals not collecting any Social Security benefits, or at least postponing the Part B. Who are those individuals? Individuals that are employed and covered under an employer's health benefit, or individuals that are married to someone that is employed and covered under that employer's health benefit. So things to consider if you're going to be delaying this enrollment. If you pick up Part A or Part A and Part B, that could be a supplement to the employer's coverage. Part A, for most likely, is going to be a zero premium, and it's not going to cost you anything additional, but Part A could also screw up your utilization of the employer health benefit, so be careful. Getting Medicare could be helpful in supplementing the cost of the employer benefits. Part B is going to have a premium cost, which might not be worth that supplement. And having any part of Medicare, even the Part A part of Medicare, in many instances can actually screw up your utilization of the employer's health benefit, so be careful. Who does not have to pick up any part of Medicare? An individual that is not collecting any part of Social Security. They have the right to say, no, thank you, I don't want A or B. Will they be penalized if they're covered by an employer health benefit at the point in which they reach eligibility? They're not going to be penalized if they postpone entry into Medicare, the A or the B portion, if they can. And certainly not the B portion, even if they're collecting Social Security. They can pass on that and say, I'll get to it when my employer health coverage is terminating. And here's a big warning. If any of you out there are employed by small employers, or you yourself are a small employer, or have some kind of private insurance leading up to your entry eligibility for Medicare, the rules of delay truly only apply to individuals that are employed by large employers. What's the difference between small and large? The number 20. Less than 20, small employer. Less than 20 employees. 20 or more employees, large employer. Why is that important? If you work for a large employer, again, 20 or more employees, then the presumption is the employer's health benefit is the primary coverage. At most, Medicare will be a secondary supplement to the employer, and the employer cannot force you into the Medicare system. That would be discrimination, typically under the ERISA rules. However, if you work for a small employer, less than 20, or it's just private insurance that you have, when you become eligible for Medicare, very, very possibly, that benefit could significantly change, whether or not you pick up Medicare anyway. And certainly if you do pick up even the portion of Medicare, like, well, Part A doesn't cost me anything, I'll just get Part A. You may have effectively shot yourself in the foot, particularly with a small employer. That act of picking up just the Part A may have abrogated that small employer coverage from covering anything of you, certainly covering as the primary benefit. And often I find that clients come to me well after they've turned 65, usually when they've submitted a claim on their employer's coverage, to be notified that, oh, this coverage is no longer valid, or at least no longer valid for the full coverage that it promised, because you've triggered a change in the coverage by simply turning 65. But I didn't get notified. Well, it's part of your plan document, and you're compelled to look at it. And yeah, we probably should have notified you, but we didn't. and now we're not going to pay at least the entirety of the coverage amount, and you're going to have to come up with a balance. Or by the way, we're terminating your coverage now because you picked up some element of Medicare. Oh, sorry, we didn't let you know. Large employers have the capacity to be far more flexible, and their employees have the expectation that coverage is going to stay in effect as long as they continue to be employed, or if it's through the spouse continued to be employed. Small employers need to be careful and need to be vigilant and cannot necessarily count on the insurance company, their broker, their agent, the representation to notify them in a timely way. So if that occurs in your situation, or if you know someone, tell them to be quite aware of the changes that are going to be in effect. And even sometimes it happens this way. They ask their broker, they ask their agent, and the agent says, oh, don't worry about it. And it finds out he had no idea what he was talking about. The contact you make is with the company itself, and you get someone in capable knowledge of how this product's going to work, and you go through it specifically. What triggers a change? What is that change going to be? And it could be the difference of paying a significantly larger amount for the care you receive once this triggering event has occurred. But if we're working for a large employer and we've not collected, or at least up to this point, Social Security, and we have coverage through this large employer on their health benefit, you can absolutely delay enrollment into the entire Medicare system without the expectation of any adverse impact. And when finally that employer coverage comes to an end, you have an extended grace period to transition from the employer benefit to Medicare. It's an 8-month period to allow you to get all the things done that's necessary. However, my recommendation is do not expect to use any part of those 8 months. You don't need to. You don't want to. You want a smooth transition. So you're going to, here's your baby steps for, I've delayed my entry into Medicare. I've not picked up A or B because I didn't have to, or I picked up the A, but I didn't pick up the Part B. And now I'm anticipating no longer working. Or it's my spouse. My spouse is anticipating no longer working. So what should I be doing? First of all, you should be thinking about this at least 3 or 4 months leading up to the termination point. Now, sometimes you don't have that luxury. Sometimes you're notified you've been terminated out of the blue. And by the way, this is where the 8 months can come in handy. But if you are given a reasonable time, meaning you are in control of the decision to terminate work, this is how it should look. About 4 months out from when you think this is going to happen, you notify the employer, more to the point, the employer's HR unit or who's ever acting in that HR capacity. You let them know, but I really don't want to. You're really going to have to, because you're going to need some time to get some things done. And the first thing you're going to need is the employer to provide you with a document. Now, that employer is going to give you a statement which says, from the time this person was 65, from the time they were eligible to enter Medicare, they had coverage with me. And this coverage is going to come to an end on a certain date. So first of all, you're going to say to the employer, hey, look, in a few months, I'm going to stop working, or my spouse is going to stop working. And when is my healthcare coverage coming to an end based on this projected date of end of employment? This is the date. Okay. I need a document from you. In order to enroll in Medicare A and B, or just the B part, I need a statement for you. It's a formal statement. It's a document that's the templates provided by the Social Security Administration, and I need you to complete it. A large employer is likely going to be aware of this process and is likely to say, I know what you're talking about. I'll have it done for you and I'll make it available. You need that document to be able to enroll in the parts of Medicare you don't already have. That document is called a Cms L564. It's completed by the employer, usually just telling the employer that you're terminating and you need the documentation is enough for them to understand what they have to provide you. They produce an L564 for you, an L564 for the spouse. Each of you need one of your own. And then when you go to socialsecurity.gov and go to the menu section on their homepage for enrolling in Medicare only, you're going to complete not only the application for entering Medicare, you're also going to complete the document that supports that you were covered from the time you were 65 up until the termination and when that termination. That's the L564. The employer should provide it to you, if you're going to do this online, in a PDF format, an electronic form. So the employer is going to produce it, send it to you electronically, and now you can actually electronically attach it to your socialsecurity.gov application. At that point, then, you've effectively submitted your application, now with also the documentation. You do it, spouse does it, and again, 2 to 4 weeks later, congratulations. You've effectively enrolled. In case the employer has never heard of the L564, you can download it. You can go to the SSA.gov form section, download the form, produce it for the employer. It's unlikely you're going to have to do that. It's also unadvised that you mail in or have the employer mail in the L564 separately. It will get lost from the basic application itself, the 40B, and that's going to delay the process. You want this collectively submitted at the same time in the same format. So on the electronic application for getting into Medicare, it's going to say, do you want to attach anything? Yes, you do. You attach the L564. In the note section of the application, you point out the month you expect to go in, and you point out that your expectation is for them to find the L564 attached. Once you've entered into Medicare, comes the process now. We're anticipating what else you need. So leading into the process of fully integrated in the Medicare system is first picking up the Part A and Part B portion of the Medicare. If you've already picked up the Part A previously when you were initially eligible, it's the delayed entry into Part B. If you've not picked up either A or B and delayed that process, it's picking them up both. Once you have acknowledgement that you're enrolled in both the Part A and the Part B, you now reach out to the private insurance companies to pick up their additional products that will either supplement Medicare or replace Medicare. And the purpose of this is to pick up the cost sharing that was always built into Medicare, but became more critical as the actual dollar cost of healthcare services increased, and that percentage of coverage that Medicare promised from the beginning represents a larger and larger real dollar commitment on the part of the beneficiary. So to cover the deductibles and the co-payments and co-insurances, we're looking at private insurance, picking up the stuff that basic Medicare does not cover, either in total or at all, like dental, eye care, other kinds of things like that. And that's what we're going to be talking about next week, the kinds of private insurance products that we're anticipating. And which brings us now to the Q&A portion of today. So, Drew, if you want to tell me what the first question is, I will presume there's some questions.
Yes, there absolutely are. So I think that we actually addressed the first question pretty well, but just to do maybe a quick reiteration,
Sure.
um, the importance of registering within that certain time frame. So you definitely want to be registering before you turn 66, but after you turn 65. Um, based on what you were saying, you can actually start the enrollment process prior to 65 within a few months, correct?
All right, right. In fact, this is why I brought back up the PowerPoint. This is harkening back to you've got a 7-month ramping up. 3 of those months are critical. The first 3, the months that are in pink, um, if you're colorblind, the first 3 months on this chart, you still have 4 more months, but the longer you delay, the longer the delay is. So you do not, if you expect to be in Medicare in that primary month of your allowability, the month you turn 65, you do not want to wait till just the month before that. It's doable, but you're really, crunching it. The optimum time is the 3rd month before your birth month. 2nd month, still good. 1st month, it's getting a little risky. Anytime after that, you can certainly do it, but the delay means delaying accessibility and utilization of the system. What's the next question?
Okay. So if a person enrolls in a private insurance plan on, say, March 31st, are they then covered on April 1st, or does that depend on the private insurer?
Well, if by private insurance you mean the private insurance that works under Medicare, then that's going to effectively coordinate with Medicare's A and B entry. So you cannot have any kind of private insurance product under the Medicare umbrella unless you also have the platform of Medicare A and B. So basically, they're waiting, they meaning the private insurance provider, is waiting to make sure you have A and B. So you can reach out to them. And in fact, again, using this model, once you've been notified, let's say in this month, that your A and B are on track to go into effect the first day of this month, there's nothing to stop you now from reaching out to the insurance company and say, hey, I can assure you that my Medicare A and B is going into effect here, and I have my Medicare ID number. Can we submit the application now? Sure. It won't go into effect until there, but you've completed the application process. But remember, Card Horse cannot request an application with an expectation they'll actually complete it with private insurance until you have your Medicare ID number. That means enrolling in Medicare A and B successfully is the first step. Now, private insurance, as in, no, I'm in my 30s or 40s, I just need to get private insurance. Yeah, that typically is, again, last day, first day, but there are exceptions because we're not under the Medicare umbrella. Often they can make their own rules, and as long as the state's insurance commission allows them a little more flexibility, all things are possible in that capacity. Next question.
Okay. If a person has retired as of December of 2021 and has Medicare A only because they're still on their husband's Aetna insurance through work,
Okay.
this person's 65. The husband will turn 65 and retire in 1 year. What's the time frame that I need to apply for Part B?
Well, again, go back to what I said before. Anticipate that the process of enrolling is going to require that you secure the L564 from the employer. Not hard. Simple notification to the employer, but anticipate enough lead-in time that the employer is going to produce the L564 for you. And again, because you're going to be enrolling online, you want that employer to produce it in a PDF form that they can electronically send to you. Now you're going to, next step, anticipate going online to the Social Security website, ssa.gov. Each of you, if you've postponed any part of Medicare, is going to complete that portion of the Medicare enrollment that you didn't complete up to this point, the A and the B, or in your case, the B. You're going to submit it with the L564 electronically attached. You're going to wait for the turnaround, 2 to 4 weeks. You're going to keep your fingers crossed that it really is only going to be 2 to 4 weeks. And how do you know? You'll get that letter in the mail saying, congratulations, we completed it. Oh, and congratulations, you owe us some money for your Part B. Oh, and congratulations, here's your card. Then you reach out to the private insurance providers, the HMOs, the PPOs, the Medicaps, the whatever that we're going to talk about next week. And you're going to start the enrollment process for them. Now, they're usually in a afternoon or a 1-hour session. Now, it doesn't mean, literally, hey, here's my app, I guess I'm enrolled. No, it takes at least a few days for it to process. But the process of submitting the application with the private insurance company, usually within an hour or two, you've completed that. Shopping for it, you can start shopping before you actually do the application. You can start shopping when you reach a point that you want to figure out what's going to work the best for you. But the process, the mechanics of actually getting the Medicare, the part you don't have yet, getting the insurance, I would recommend strongly you give yourself at least 2 months leading into the time that you want this to go into effect. So pick the month you plan to stop working. Count back 2 or 3, and then start figuring the steps you're going to take. And keep this in mind, baby steps. I have clients who attempt to comprehend the whole thing and absorb everything and approach everything. And it's like, let me get everything done. It's like step by step. Eat the elephant one bite at a time. So the first thing I would tell a client, decide when you're going to stop working. Second thing, notify the employer about 3 months leading up to it, secure the necessary forms, go online and submit them, and then we'll go shopping for the additional products. But take them in that step-by-step process. So, long way around to say about 2 or 3 months before, not much longer than that. That gives you plenty of space and ramping up time to get this thing done. Next question.
Okay, the question here, what if you are covered by an employer provided medical plan until death for you and your spouse?
Well, Medicare could care less whether you're covered. The rule is when you reach 65, if you haven't already entered Medicare based on disability or end-stage renal, when you reach age 65, that is your normal designated entry point for Medicare. And it doesn't matter what other product you have. It doesn't matter what else. The only exception is an employer health benefit based on you being currently employed. So I have clients who say, oh no, I've got a benefit that will be there for the rest of my life. When I stop working, that benefit will continue forever. Great. Except in the eyes of Medicare, that's no longer an employer-provided benefit. It's a post-employment benefit. Call it a retirement benefit. And even if that benefit's going to be there forever and ever and ever and ever, if you haven't picked up the required elements of Medicare, Part A, Part B, you are at risk of being penalized the rest of your life for not having picked up Medicare Part A and Part B when you were required to. Now, Part A, since it has presumably a 0 premium and the penalty is a percentage of that premium, so whatever percentage of nothing is still going to be nothing. So I wouldn't be too worried about that. But Part B, if you choose not to pick up Part B because you have a benefit that will be there for the rest of your life, you better hope that benefit's there for the rest of your life. You better hope that some employer down the road doesn't decide, you know what, screw it, we're taking away. Well, I'm going to sue. It's like, good luck. We're bankrupt. There's nobody to sue left. And now you go to Medicare and say, oh, you know what? I thought I had a benefit for the rest of my life. I need to go into Medicare. You know, how old are you? I'm 85 now. Whoa. For every year you coulda, shoulda, woulda picked up Medicare and didn't, there's going to be a 10% penalty added onto the cost of going into Medicare. So let's see, 85, well, that's 20 years. So 20 times 10, oh, that's a 200% penalty for the rest of your life. So it's not just the cost of Medicare, Part B, we'll say, it's 2 more times that on top of the premium. So if the premiums, I'm rounding it up to 200, for everybody else, it may be 200, or at least the base amount. For you, it's going to be the 200 and a 200% penalty. For you, it's going to be $600 or more. So be careful. And I have individuals that say, I have a benefit which will be available to me forever and ever and ever. Like, for instance, federal employees. How ironic. The federal government creates a means by which individuals don't have to. I have a benefit that I could utilize forever and ever and ever, like the VA health benefit. You better hope that benefit is really good, really effective, and truly isn't existent in the way you think it's going to be. Because once you've passed on picking up Medicare Part B specifically, and once you are no longer covered by an employer's employment benefit, transitions to something else, now the penalties start being calculated. And you may not be able to afford incorporating those penalties on top of the rest of the cost of being in Medicare. So, warning given. Next question.
Okay. There has been a lot of talk, and there are definitely things in place that are going to require certain people of certain ages to retire at older ages. Is there any talk of requiring Medicare to be delayed until, for example, if you retire at 67, will Medicare then be required to move towards 67, or will it always be 65?
Nothing will always be anything. There was a strategic decision made on the part of the government, and it was a combination of legislative and executive process that escalated the entry point for Social Security from what was presumed always going to be 65 to a point that it's approaching 67. It's incrementally approaching, but it's approaching. So at some point, individuals have you can go in early, 62. You can go in when you reach normal retirement, which is going to soon approach 67, or you can postpone to 70. Medicare is 65. It's been 65 since it was created, but that doesn't mean it will stay at 65. And as we've seen, it isn't tied to Social Security anymore. It used to be 65 was what everything happened. Now you have to kind of juggle the idea of, like, when do I want my Social Security? When is it strategically the best time? And also, when is it strategically the best time to start my Medicare? So, that's tied into the crystal balling of, will it always be? I don't know. Will Medicare always be? And what's it going to look like as it evolves? So right now, I can tell you 65 is the magic year. Postponing it is certainly doable. You're not forced to postpone it. If you're working and have employer coverage, you can say, I don't like my employer coverage. I'm going to take Medicare. Once you turn 65, if you are a U.S. citizen, you are guaranteed access to the Medicare system. How much that's going to cost you depends on how much your Part B is going to cost, depend on whether you paid into the Medicare Part A system for the required orders necessary to get it at zero. But you're not going to be barred from it. And it being postponed to a later, wait and see what Congress has up its sleeve. Next question.
Okay. Is an insulin pump and continuous glucose monitor considered to be durable medical equipment?
Typically, the way it's recognized now, this is durable medical equipment. But again, wait and see how things get changed. Let me put it this way. And this is the core of a presentation that's going to come later. Things that were absolutely positively a certain way, you can absolutely count on it. As long as the sun shines, the river roams, and the buffalo graze, nothing will change. Well, until we discover gold in the Black Hills. Well, that changed. Now, see, it changes when it becomes economically beneficial to the government and whatever other interests are at play to change things. The reason I take a minute to point that out, for the longest time, certain procedures, certain things, which were categorized in a certain way, and quite honestly, had the benefit to the beneficiary of being most cost effectively covered in a certain way, got changed, got simply changed by waving a magic wand and saying the definition is no longer what it is. It's now recategorized, reclarified. And it's done that way, not for simplicity, not because of logic, for God's sakes, not even remotely close to logic. The logic behind it is, how does government and how does private insurance save money on their part and pass more of the economic burden to your part? So it worries me that the government is talking from time to time about shifting kinds of things that are recognized as part of the process of introducing medications to your system as now being simply part of the giant prescription drug coverage umbrella. And that is what you don't want. Here's something else you don't want, in case you don't attend the presentation later this year, not next week, but down the road. You don't want your medications characterized as Part D pharmacy obtained self-administered medications, when rather those medications could be administered in an inpatient or an in-office or in-clinic procedure. Some of the most expensive medications are typically delivered in an intravenous or injected process. Now, I'm not talking about insulin. I'm talking about the heavy-duty, complex chemotherapy type medications, not just for cancer, but for lots of different circumstances. These are the ones that are not measured at a few $100s a month. These are the ones that are never going to have the government say, hey, don't worry, $35 a month gets you all the meds. These are meds that are going to be measured in tens of thousands of dollars per month. And the great thing about that is, if that drug is administered in an office format or an in-facility format, you can create a coverage mechanism that absolutely covers the entire cost of that med. A combination of Medicare Part B for its portion of the outpatient service, which this drug is included as part of, or the durable medical equipment is considered part of, and a supplement, which we'll talk about next week, can guarantee that the entire cost, even if it's tens of thousands of dollars, is fully paid for by a combination of Medicare and the private insurance. When Medicare insists and pushes and bludgeons the providers, whether it's a procedure or equipment, into shifting the definition and shifting the accessibility to a Part D, D for drug mode, they've just shifted thousands or tens of thousands of dollars of cost to the individual. Why? The logic of it? Well, the logic of we don't want to pay for it anymore. And individuals that are faced with excruciatingly expensive costs for drugs, costs for application of those drugs, are finding more and more that the government and the private insurance enhancements of the government are abrogating that responsibility and shifting it to the individuals. And surprise, individuals are now faced with coming up with that money, and all the retirement planning, all the financial wisdom that came about can't save them from the wolf at the door. And often I have individuals that are facing bankruptcy or terminating healthcare services, so they avoid bankruptcy, which leads them into another more dire situation. And we're back to the bad old days of the pre-1960s, when it was a question of, if we do this, it's going to be economically devastating to us. It means giving up everything we've worked so hard to achieve. Or maybe we just won't do it. Maybe it's our time. And that kind of burden to the family is, I don't want to be that economic disaster to my family. But the family's saying, no, we don't want to lose you. What a terrible situation. How else can I brighten your day, guys? What's the next question?
Well, Bill, actually, that was the final question that I had for you today. I just wanted to take a moment and thank you very much for your time, and thank everybody who attended today for their time. I think that this was incredibly insightful and useful information. If you haven't already enrolled in Part 2, you can do that on our website at ameriserve.com/presents. Just enroll for Part 2, which is going to be held next Thursday, the 31st at 10 a.m. There will be a fresh link emailed to you if you haven't already enrolled. When you do the enrollment, you'll get a link in your email that gives you the link to that session. And we are, as Bill sort of already alluded to, we are going to be holding some additional sessions with Bill throughout the rest of this year as well. So keep your eyes peeled for that. And I think that pretty much wraps things up for today. So,
Before
Bill,
you
thank you
adjourn,
very much for your time.
Let me insert
sure.
one other thing real quick. If you think of any additional questions that weren't addressed today, you on the very first slide is my email address and my telephone number. You can certainly reach out to me. Be more than happy to. And there was one other thing that popped up on the screen. Can you make the PowerPoint available? If you guys want to make it, Drew, the PowerPoint available, that's fine. Or I can make it available, no problem. So if it's a question you want to ask, send me an email. If you want to get some additional information, more than happy to submit it to you. Either way, just drop me a contact and I'll try to get back to you as quickly as I can.